Morning, Rotarians and guests. Welcome to the Rotary Club of Hudson. I'm Ron Strobel, the Sergeant at Arms. Our invocation this morning is by Rich Warfield. If we can get him out of his corner.
Oh man, long walk. Come on. Somewhere for us.
Do I get the next stand next to the Sergeant of Arms? Good morning, ladies and gentlemen. Let us bow our heads, please. Heavenly Father, thank you for this time today with these men and women at Rotary. Let us be blessed with each other's presence. Lord God, we pray for world peace amongst all men and women. And Lord, we pray for this time with our speaker. We pray for these politicians these days, Lord. Let us have our best interest in mind when we elect the next person to lead this country. Lord God, I'd like to pray for a very special person in my life, Rachel Penix, who has now been diagnosed with brain cancer again. Please put your hand of protection over her and let this food nourish our body on this great day. Amen.
Thank you, Rich. And lead us in the pledge and four-way test, Tom Tobin.
Good morning, Rotarians. Please follow me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all. And now the four-way test of the things we think, say, or do. First, is it fair? Truth. Second, is it fair to all concerned? Third, will it build goodwill and better friendships? And fourth, will it be beneficial to all concerned?
Thank you, Tom. And filling in this morning, Terry's plane evidently was delayed. So Marilyn Orr will be leading us. I was skipping that.
We are definitely skipping the song. Oh my goodness. Well, although I am your past president, I think you remember that I was president of this organization during the COVID years, 2020 and 2021. This is officially the first time I am standing behind a podium. So yay! Isn't it wonderful to be back? Isn't it wonderful to be back live? Okay. Well, just a recap of a few things that are going on. The Gala Committee is going to be meeting again this Friday. And at the end of the meeting, I'm going to give you just a little recap of the beneficiaries because I'm very, very, very excited about some of the things we've got going on and how we are partnering with new people in our community. This is the last day that we will be meeting at here and bringing in donations for the Haven of Rest. Now, today's the last day of January, but you know, tomorrow is January 32nd. The next day is January 33rd. If you haven't brought anything and you'd like to make a cash donation to help support this effort, just get your money to Terry. You know where she works at Howard Hanna, or leave it today and I'll get it to her. So it's a good cause. It's cold out there. Everybody needs clean socks and warm feet and warm hands and fingers. The Board of Directors will be meeting in February as well as the foundation. So look for the communications about those to confirm those dates. And then that pretty much takes care of what I have to do as far as introducing the meeting. And I'm going to turn it over to David Basil, who's going to introduce our speaker today. And I'll meet you on the back side. All right.
Thank you, Marilyn. Good morning, fellow Rotarians and guests. It's my pleasure to introduce today's speaker. He is Dr. Nicholas Pleat. He graduated with a bachelor's degree in biochemistry and molecular biology from Rollins College in Winter Park, Florida, and earned his medical degree from Lincoln Memorial University in Harrogate, Tennessee. He received his internal medicine residency training at Good Samaritan Hospital in Cincinnati and completed his hematology oncology fellowship training at the University of Oklahoma. He is board certified in internal medicine, hematology, and medical oncology through the American Board of Internal Medicine and is a fellow of the American College of Physicians. He is married to Emily and the proud father of 3 beautiful daughters, Piper, Hadley, and Collins. Dr. Pleat loves spending time outdoors with nature, caring for his trees, woodworking, and learning the art and history of bourbon distilling. That sounds like fun. It's my pleasure to introduce Dr. Pleat. Please join me in giving him a warm Rotary welcome.
Well, I want to say thank you very much for this opportunity, guys. This is an excellent. When it comes to the bourbon thing, I had to be very careful because that was my blurb at SUMA, and I'm a very it became a passion of mine a long time ago in learning the art of bourbon. So I couldn't say I love bourbon, because then they say, you know, let's try to frame that a little bit more politically correct there instead of saying one of our oncologists loves bourbon so much, you know. So that's kind of how it worked out. But yeah, so you know, I had to be very careful about that and stuff. But first off, I want to say again, thank you for this opportunity. And I was asked to talk today about something that I want to give you. I wanted to break something down very simple, but I also wanted to give you a lot of things to think about, because we were asked to talk about something that is also becoming a little controversial, and it's going to be more complicated in the future. And that is really cancer prevention and screening. And what do we do kind of going forward? And what are the future directions of that? And the reason why I say this is going to be, you know, a little bit different than what you might think is that you're going to see very similar things we did 20 years ago still today, with very little advancement. And then you're going to say to yourself, out of all these things, where are we going with this? And that's kind of where we're going to have this talk today a little bit about, okay? Next slide. So what I want to do is I really want to kind of highlight, really, this just came out. I don't know if everybody saw it in the news. It was a big thing on Good Morning America and everything, but I want to go over the latest 2024 facts and figures of where cancer care is really evolving. And then, you know, I think to set the tone of kind of where we're at with this whole process about screening, prevention, where we're going. The most important thing after that is I want to go over what the standard of care is right now. So when people ask, what do we do? You know, how do I guide myself, my family members on what to do? And then really, I want to talk about a little bit about future directions. And this is a little bit of the controversy of where we're going. I'm one of the youngest in our group at SUMA. So, you know, I tend to be more, I guess you could say, they call it technologically advanced, or the more, you know, forward-thinking folks. So my future directions really are going to a little bit different than I think the approach that was about 20 years ago. So, and then I'm going to give a little blurb about what we do here at SUMA Health. I want to talk about our institute and kind of leave it open to questions after that. Okay. Next slide. So I have no conflicts of interest or any of that to report. Required to do that. So if you were, go next. All right, so let's talk about some statistics, okay? This is from the American Cancer Society 2024. By the way, before I start, you can leave it on this slide. The American Cancer Society is very dear to my heart. They are an amazing institution and organization. They actually gave me a scholarship when I was at age 17. I had my own personal diagnosis of cancer at that time. So they have always supported me, and they're a very good organization. So I always just want to give them a shout out to, okay? But basically, what do I want you to get out of all of this, really, in here is, in 2024, we're anticipating at least 2 million new cancer cases projected, okay? For the first time ever. That's the highest we've ever recorded. That's the highest it's ever been recorded. Can you hear me now better? Okay, sorry. So 2 million new cases for the first time in 2024. meaning that we're going to seeing the higher incidence rate. What does incidence mean? That means new cancer cases diagnosed. That does not mean morbidity and mortality. That's just new cancers diagnosed. So I'll talk to you a little bit more about that in the later slide, but 2 million more cases. All of these people, this is the one most important takeaway, I think, is that colorectal cancer now, when it comes to cancer deaths under the age of 50, is #1 in men, #2 in women. I anticipate this to be #1 in both subsets within the next probably 3 to 5 years, in my opinion. This was well overdue. I predicted this a long time ago when I was in fellowship, seeing younger people with this disease. And I'm going to explain to you the controversy behind that a little bit. 4 screenable cancers are on the rise, and that's another thing we're going to talk about. Again, there's a little controversy there. Again, is diagnosing more cancers good? Or is it really, what is the outcome of screening? Okay. And then I want to put out this here is that this is the United States. In Ohio alone, we're anticipating about 76,000 new cancer diagnoses in this coming year alone. Let me put that in a different perspective, okay? There's only about 40 or 50 oncologists just in Northeast Ohio. Overall, I mean, we can't keep up with the demand, basically, of the rising incidence rates of cancers. And so it is going to be challenging going forward with more cancers being diagnosed, the treatment's becoming more complicated, much more genetic approach, the exploration of so many new treatment options that, you know, in Ohio alone is very important that we have institutions that are going to be kind of on the forefront of where we're going with things. Okay, next slide. What do I want you to get out of this? So this is a busy slide, but I kind of want to show you a few things that are very important here. And the most important thing I kind of want to highlight here, if you just bear with me, is I want to show you something called pancreatic cancer. This is something that I really want to kind of drive home the point of being diagnosed with something versus morbidity or mortality. Basically, what's your likelihood of dying from the disease? And then how do we go about screening for that? Okay, just so follow me here. Pancreatic cancer, the new cases were anticipated is 66,000 this coming year. Of that, the estimated deaths up here is 51,000, meaning that you're about 92% likelihood to die from the disease. Compare that to something as like, I just want to kind of show you an example of like melanoma. Everyone says is so dangerous. 35,000 new cases, only half of them would even die of that disease. The other ones are like breast, 313,000 new cases, 42,000 deaths were expected. So you see the rate of diagnosis versus outcomes are different markedly across the board. Because I know the next question people are going to ask is, well, why can't you screen for pancreatic cancer, which we're going to talk to shortly, okay? You can go to the next slide. So of this, I just want to take home one point here, and that is, what is the estimated, basically, this trend hasn't changed, believe it or not, since I've been in fellowship. What is the most likely diagnosis of cancer that you're going to die from? And you might want to, you can advance one thing. Oh, go back, is that lung cancer still is the #1, both men and women, okay? It has not changed, and that has always been, in my personal opinion, how I explain this to patients is lung cancer is a man-made disease, period. So this did not exist. We actually have archaeological data, you know, hundreds and hundreds of years ago, before cigarette smoking came about, and none of the changes we saw existed today. 90 to 98% of all lung cancers in particular are associated with some sort of smoking. So if you think about that, that is a man-made disease, in my opinion, but it's still the #1 most common and also likelihood of death still to this day. And that's been that way for literally almost past 20 years. And then you're going to see, now, when it comes to new cancer deaths, still in men, it's prostate followed by breast. Pancreatic is #3, or right around #3 or 4. Again, it's for an incidence of 300,000 breast cases versus 60,000 pancreatic cases, but still, from a death rate, it's still very high. You go next slide. So here, the trends of where we're going. This is from 1975 up to really, this is, we're waiting on our 5-year data to come out on that soon. But if you look at it, it says basically the 5-year relative survival rate. Breast has improved, colon and rectal, minimal. All these other ones and stuff, but pancreatic hasn't improved pretty much at all. As well as some of the other ones here. Liver hasn't really changed much, but basically we have made a difference across the board. But again, it's been minuscule in each individualized cancer. Go to the next slide. So this is just explaining kind of the trends in death rates from the past really almost 25, 30 years plus. And you can see that the mortality rate in both males, females, and combined have all gone down. And then the question is, oh, well, that's great, we're doing good, but why are we seeing more cases if we're doing so good? So go ahead, next slide. And then this is just another way to take that home. That point is how many cancer deaths were averted. This is from 1975 to 2020. And you can see here about 3 million deaths were cancer averted based on screening protocol as well as on new treatments and other things. And this is just kind of putting the point here that we're saving a lot of lives with the work we are trying to do. So this is a very interesting slide. So, and I'm going to have a comparison to the female after this, but the death rate in men, this is important. This is from 1930 all the way up to now. But I want to point out, remember I said lung cancer essentially is still the most common thing. You look at 1930, this is probably because we didn't really have much screening back then. But you see, this is when we started getting, this is when the advent of what we call CT scans really came in about. And you see that the death rate, when we started picking up lung cancers, went up dramatically. Okay. And then you're seeing a plateau. And that is simply because of the fact people are smoking less. There's been cessation efforts and other things, but it's still, so you've seen this massive peak here. This is when screening and other things changed. And then kind of the commercials of cigarettes are cool kind of went away. And now you're seeing a big drop in that. But I do want to point out one couple other things. I kind of might sound like a broken record here is, but colorectal, you're seeing just a little change, not much. You're seeing something like prostate, which is basically the same. So this is interesting. Keep in mind, prostate cancer from 1930 to here, when it comes to death rates, really, you had a peak here, and then here it's gone down a little bit. Hasn't changed dramatically. But we have diagnosed more prostate cancer in comparison. And then the last one I want to show you, just for, I know I sound like a broken record here, but pancreatic cancer, nothing's changed. And it really pretty much minuscule change over the course of almost, literally we're coming up to close to 90 years at this point. All right, next slide. Women, same kind of notion, lungs, and what you're seeing here is the same kind of phenomenon, and it's plateauing down as well. The one is for breast cancer, you're seeing that it also is going down as well. But again, we're picking up more breast cancers, but you're actually seeing the improvement is still minuscule in overall numbers. And you see the same thing with pancreatic and stuff, no change pretty much. All right. And then next slide, I'm sorry. So you can see here that, you know, if you talk about race, ethnicity, and all the other stuff, I just want to point out there is a discrepancy. And the fact that, you know, if does your people always ask does my race, all this stuff have an impact? And it's controversial, but right now I can tell you that the current statistics show that the highest death rate in females is of the American Indian population and Alaskan natives. And in men, it is the African American population. So, and you see there's a discrepancy between that, and we'll kind of end up leaving it at that. So, next slide. So that's the trends. So what I want you to get out of all this is that we've made some progress. We have diagnosed a lot more cancers. Some have shown a marked improvement, some zero improvement. So then the question is saying, well, what can we do to screen more people in order to us pick things up early? And this is where my view on this is going to be a little different at the end. How can we pick up more cases early so we can prevent more deaths? That's kind of the theory behind all this. And so that's why we're going to talk about screening, prevention, and other things here in a minute. So this is a Summa Health thing. This is really again, I want you to, I'm not trying to bash oncology or our USPT task force or anything. It's just what we do for screening is archaic. It just is. Over the last 30 years, nothing has changed. Okay, this is the big one that changed, is that we do a low dose CAT scan of the chest once a year if you have a certain history of smoking and you're over the age of 50 pretty much. So, that is really, we have something called a lung nodule clinic at Sumo Health that I participate in once a week. It's a conference in which we basically review these scans of people who come in, they don't have symptoms yet, but if we can pick up small nodules early with this smoking history, we can intervene earlier before it becomes dangerous. That's really been the only thing new in that from a technique standpoint over the last 30 years. Okay. Colorectal is colonoscopy. Now, we just, hopefully there's no insurance folks on the line here. We just lobbied for a long time for insurance companies and others to finally approve starting colonoscopies at age 45. Why? Because it is the trend of people less than 50 is the #1 highest rate of both cancer-related deaths now we're seeing in incidents. I saw this as a fellow. I'll never forget in Oklahoma, we'd have these conferences, tumor board conferences, very young people in their 30s, 40s, and we had nothing, we couldn't do anything about it. We said, why couldn't they have undergone a colonoscopy earlier or done something? Because the old recommendation was age 50. So we knew that the age 50 and above, really 60 and above, their incidence rate and death rates were declining, but the ones below 50 were increasing. And it was because of the fact there was no screening until age 50. And so at that point in time, when we saw younger people more and more coming in, and they were coming with much more advanced disease because they weren't undergoing colonoscopies because it wasn't approved. So you couldn't get it approved and say, hey, look, I want to just get a screening colonoscopy at age 40 without certain risk factors or family history. None of it ever got approved. Insurance would approve it. It's not the standard of care. And so we were kind of at a loss. But we finally, after a lot of data being pushed, we lowered that to age 45. I think that's going to be lowered to the age 40 at some point in time. And so that's an important concept that's changed. Breast cancer, nothing has changed, essentially. It's still mammograms, essentially, in clinical breast exams. But at the same time, not everyone's an expert at examining themselves. So we do try to give advocation to that, but really it's still mammograms. Cervical health probably doesn't apply as much to this audience as much, but it's for younger folks. It's really pap smears and HPV, which I'm going to kind of exclude for this talk. But the other one is prostate cancer. This is a big change that's occurred over the last probably 5 to 10 years. But there is not a routine PSA screening anymore. I'll explain that area in just a bit, but that's all we have. So basically talk to your doctor, mammogram, a colonoscopy, maybe a small CAT scan. That's it. It's not too much change really over the last 30 years. So just some different nuances on how we approach it. So, okay, go to the next slide. So for breast cancer, this is where I kind of want to highlight a few things here. This is just talking about the age of when you start it. But the more important thing here is, when do you stop it? This is kind of, go to the next slide. This is trying to be politically correct here as possible. This I don't agree with, but it is something to discuss with your doctor one-on-one, is that when is the balance of benefits and harms? And they're saying that over the age of 75, screening people routinely with mammograms is, they say here, insufficient. I disagree. And the reason is I think you should evaluate each person individually. I mean, I have seen it a lot. I saw someone the other day, they literally were 93 years old. They were literally coming in with a tracksuit saying, I run every day. They look amazing. Are you going to treat her differently just because of her age? I mean, if she had an early stage breast cancer that could easily be removed, that's the controversy. And so does age alone predefine screening cutoffs? And so I just wanted to point that out, but everything else is pretty much the same, is that, it really starts at age 40 and goes on. But I just want to give the idea of that it's a lot of people come to me and they say, I don't need mammograms anymore. I'm 75 or I'm 76 and this and that. Well, I think it should be an individual discussion, especially if you have a history of anything breast cancer related. But that's kind of where we're at with that. So, all right, next slide. So this is important. Again, the big change was, and the ACS recommended starting at age 45. That is well overdue. I think, so you're probably wondering, why are we seeing younger patients with colorectal cancer? I'm seeing an epidemic of it. When this data came out, I was not shocked at all about the rising trend of this. A lot of people are saying it's our obesity epidemic in particular. And then there's so many controversies about, is it purely diet? Is it exercise? Is it insulin resistance? Is it this? But the obesity rise, you'll see an overlapping in some studies. The obesity rise and colon cancer rise are almost exactly at the same curve. So I do think that it's not been proven, but it is a risk factor. But I do think that the rise of colorectal cancer we're seeing have a lot to do with the obesity epidemic and the things that occur with it. And so this is another thing of controversy. And if you're in good health, you continue the colonoscopies, this magic number of 75. Then after that is talk with your healthcare provider. Okay. So again, same concept as breast. Somebody who is completely healthy, they could have a grade 1, or very stage 1, favorable colon cancer could be picked up, and they could easily go through a resection and completely not develop any issues. Where do you cross this line about screening cutoffs? Okay. So, and then they say over 85, they should no longer get the screening. And the idea is the fact that we measure outcomes based on life expectancy. And so they're saying, basically, in a nice way, people are more likely to pass of other things beyond the age of 85 than a potential colon cancer in a 10-year period of time. So picking up more of them would basically cause more diagnosis, but the outcome might not be a change in cancer-related deaths. Does that make sense? Okay. All right. So you can go to the next slide. This is the same way to look at it. The only thing that's new, again, is really changing from 45 to 75. After that, it's talk to your healthcare provider. I don't really know what that means, personally. I think it should be a one-on-one discussion with people about risk-benefit ratio. It should be individualized, but a clear cutoff. It is difficult because some payers, insurance, and other folks will not approve certain things. So you do have to kind of advocate for patients if they really feel the need to get the screening done. Now, the next one is very important, okay? Prostate cancer, okay? Now, so there was a mentor of mine in fellowship. To this day, he's probably the smartest man I've ever met. And his name's, he's the director of the Johns Hopkins Cancer Center. All he does is study prostate. But he is a very common sense guy. And what he did was, as a study, when I was a fellow, and he gave us a grand rounds on this, is he said, we were screening everybody's PSA all the time back in the day. Everyone was getting a PSA screen. And we were picking up so many more prostate cancers, but the death rate didn't change. Mortality rate didn't change. So everybody was getting these very uncomfortable 12-point rectal guided biopsies, doing all this stuff and everything. And why was that the case? So literally what he did is he literally went down to the morgue. And what he wanted to do is go to different people who had passed and essentially biopsy their prostates. He wanted to see how many of these people who had passed from other things had prostate cancer. And the rules were in the 10s. So I'm in my 40s now. So I have a 40% risk of having some degree of prostate cancer. So if you're 90, you'll have 8% risk of prostate cancer. But prostate cancer can be an indolent disease over the course of the fact that most people will never have a problem from prostate cancer itself, even though they had the diagnosis of it. So hear me out on that, is that prostate cancer is an indolent disease in a lot of cases. And we actually measure our ability to say, do you need treatment or not, based on life expectancy? Because we found that more of the treatments we did caused more harm and more diagnosis because of the fact I mean, androgen deprivation therapy is one of them, where you lower testosterone, quality of life goes down. People are getting prostates removed all the time. The question is doing more necessarily good? And in this situation, we found picking up more cancers did not make a clear benefit. So it's very important to point that out, because going back to the analogy about biopsying stuff, is that it wasn't that it's like a new diagnosis that has to be addressed. This is probably, in my theory, and his theory, is that why are breast and prostate cancer the two most common cancers? Well, a lot of people believe that, from a biologic standpoint, these are reproductive organs. Are they supposed to start degenerating at the age of 50? Are they supposed to start seeing cellular changes after the age of 50? Because our life expectancy was never like this before in the history of mankind. So the longer we're living, is it because we're picking up more cases simply because these are supposed to be degenerating over time and seeing these cellular changes? Obviously, that's another talk for another time. But so now, if you look at the actual screening for prostate cancer, it really is again, talk to your healthcare provider. Okay. So what are the risk factors of this? Really, African-American men, really, if you have a family history, but those are the two main reasons when you say, should we do a screening PSA or not? And the problem with PSA screening is that PSA elevations can be seen in a lot of things other than cancer. You have a urinary tract infection, prostatitis, other things. And then you go down this big rabbit hole. Then you have to get ultrasound guided biopsies. Then you have to get scans. Then you have to see urology. Maybe you need something called external beam radiation therapy. Again, PSA values have a role, but mortality rate in picking up more low risk prostate cancers has not made a difference after a certain age. Does any of that make sense, or did I just confuse everybody? Okay. All right. Next slide. Lung cancer. Again, did you smoke? And then when you say 20-year pack history, all they're saying is basically saying that if you smoked one pack or 20 cigarettes, I don't know how anybody counts 20 cigarettes each day for whatever, for at least a year, that's a pack history. Basically, if you smoked for really 15 to 20 years, you're getting a CT scan. No one's gonna say if you had 19 cigarettes versus 20, but the reality is it's a low dose CAT scan of the chest. And what is the problem? This is just kind of a diversion here of getting CAT scan. People, I get patients all the time after I treat them with a very aggressive cancer and they're in what we say a remission status. They say, I want to get a scan. I want to make sure nothing's there. I get it. I'd want that. I want to scan every month. Heck, if you saw what I saw every day, I tell them you'd be paranoid too. You want to get a scan all the time. The problem is excessive radiation exposure over time will actually can be more harmful. So, for example, one CAT scan full dose can be equivalent to almost 1,000 X-rays in radiation exposure. So when you see that, you say to yourself, hey, look, you'll glow like the sun if I get scans all the time. And, and we know that from, Nagasaki and when the nuclear bombs were dropped, that nuclear exposure, radiation exposure too much is harmful. So when it comes to getting scans all the time and everything else, there are harms with it. And then you also go down the rabbit hole of what we call incidental findings. I see a little, like I had someone the other day, I'm not kidding you, went in for the ER. All they had was, I think I have COVID, and they found a mass in their pancreas with the CAT scan. And, the ER is the ER, but they were told, oh, it's a pancreatic cancer, all this stuff. And they literally were so upset. They literally flew their family in from Washington State saying, oh my gosh, we got to have end of life talk. And I got a different scan that's called pancreatic protocol MRI, and turned out to be a cyst. Okay, so all of that and those are totally benign. So all that anxiety, all that stuff can be much scans, and it can lead to a lot of unnecessary, really, I guess, stress in people's lives without really knowing the clear risk and benefit ratio. So, all right, next slide. So for cervical cancer, the only thing I want to point out here is this thing called this HPV stuff, okay? HPV is not necessarily a sexually transmitted disease anymore. It is basically, HPV is almost everyone's exposed to it at this point in time at some point in their lives. And so in HPV in particular is extremely common as the underlying cause for head and neck cancers, obviously cervical. Really, there's a lot of cancers that are being associated with it. And now we have a HPV vaccine that we recommend giving to young kids, even though they haven't been exposed to it, because it is a preventable thing as HPV-driven cancers. If your body essentially gets HPV, you develop an immune response to it. So therefore, you can try to prevent a cancerous development from that. It doesn't really apply, I think, to this audience too much, but just to keep that in mind of where you're at with that. So next slide. These are the two things I want to point out just for completeness. I get this a lot of skin cancer. Should I get a skin exam or should I see a dermatologist? Hopefully there's no. Okay, better not be a dermatologist in this room. Okay, good. Is again, they love to do those. I'm going to freeze this off, I'm freezing that off. Everybody, you know. Okay, the reality is skin cancers in general, asymptomatic adults who don't notice something in particular, I'll come back to that in a second, they basically say you do not necessarily need, there's insufficient evidence to determine whether you should even get a skin exam. These things that they, and again, the only really death that occurs from skin cancer is melanoma, and melanoma makes up 1% of all skin cancers. So 100 people get these screening exams, maybe one person would get, find a melanoma. It could be even early melanoma where it just needs resection. And of those melanomas, only roughly about 30 to 40% have metastatic disease at some point and actually can potentially die from it. So again, you're looking at extremely small numbers, and these things they burn off or other stuff, basal cell and all this other stuff, those do not correspond to really a cancer-related death. So it's very important to know that. So again, getting everything burned off all the time, doing all that, it's not a current screening protocol. And then the last thing is, this is the new hot trend is, should I take a multivitamin? Should I be taking all of these supplements? Will that help? As of right now, we do not have any, the 2024 recommendation is basically, right now, we don't have any evidence that a direct certain multivitamin or supplement is recommended for cancer prevention per se. So those are the two things that I think I just want to include, just because some people ask me these questions a lot. So, all right. Now I'm going to talk about, I'm not going to spend too much time on this, but I do want to give you some thoughtful questions is, where are we going here? Okay. These are the three, this is what prevention, the current definition is. When do you intervene, right? Primary prevention is actions that keep the disease process from becoming established in the first place, hence that HPV vaccine idea. Secondary, early detection of asymptomatic disease, hence the screening mammograms. This is where we're at right now, essentially. Last one is tertiary, is that treatment for patients who are symptomatic from the disease. Someone comes in, their skin is yellow because they have a massive, big pancreatic or liver mass. Okay, then it's pretty much prevention's kind of out the window, but you're at that point in time, you're actually gonna have to involve some treatment to try to prevent worsening issues from occurring. So you can hit the next one. This is the future, in my opinion, is instead of us going from a secondary where we're at today, is going to, how do you keep the disease process from occurring in the first place? And then you can go to the next slide. This is where I think the future is going to be all on genetics. Okay. Again, I'm the youngest in my group, so there might be some discrepancy here. There are a lot of controversies with this, but I think the future, maybe I'll have this talk with you guys again in 5 or so years. You'll say, oh, he was actually somewhat correct. I think the future is going to be with any cancer is that the old staging mechanisms of things, how we looked at it, are going to be completely archaic. And the reason for that is, I think we know the fact, lung cancer, for example, there's really 3 main types, but each one of them have completely different genetic profiles. On top of that, some can even now just get a pill with metastatic lung cancer if they have that genetic profile. So we actually test for these things up front when they have the cancer. So then the question comes down to, let's say, for example, you have a BRCA1 or 2 mutation. we know that corresponds to breast cancer risk. Early intervention at that point in time, would that be beneficial? Which is going to be when you're actually diagnosed with cancer, we're literally going to sequence the tumor DNA, not your DNA, the tumor DNA, looking for what's driving it. And then you're going to see a whole different list of treatment options directed, personalized to your treatment. And that we're already going there with now with immune therapy, what we call molecularly targeted therapy, chemotherapy. When I give lectures to residents, the first slide I always put up is a picture of the Civil War. And they always say, oh God, here goes Pleat again. And the reason for it is you look back at that time, and when someone got shot, what was the treatment? That looks barbaric now, right? People are just, you look at that, you say, that was barbaric. I think that's where we're going to look back and say, you were giving quote unquote poison chemotherapy in general to folks when you knew that these people would respond based on their genetic profile, these people would not. And I do think it's going to be much more very similar to that idea. But again, the last 30 years, that's all we had. And we still rely on it a lot now, but it's becoming much more personalized in the care. So when you see things like this is the hereditary cancer risk, this is just one example. I just put it up here. We now have something called Oncotype DX that we use in breast cancer risk to determine after you're diagnosed with cancer, based on the genetic profile, do you even benefit from chemotherapy at all? And that has been validated. And we found that almost literally a lot of places, 90% of patients don't even need chemotherapy, even for a lymph node positive, potentially breast cancer. So, this is where the future is going to be going with all of this. And I'm trying to, the problem here is from an ethical standpoint, I got to be careful here. Screening more people on a genetic profile, what would be the harm in that? Particularly, let's say you're an insurance company and you say, I got screened and I have a BRCA mutation, all this other stuff. I don't have anything wrong with me yet. Well, your premiums are going to go up dramatically because your risk of cancer is higher. So you see the controversy there. You see how people will be treated differently simply because of this screening modality. And so for a fact, like for example, someone has like a CHD1 mutation specifically for gastric cancer, which I have a patient right now who has that. He's only 38. All of his children are going to have to be screened. How do you address that? And so are people going to be treated differently because of this genetic stuff? And then you have we live in a very social media world now, okay? I call it the Angelina Jolie effect, okay? So she was on the cover of every magazine, and she got something called 23andMe done, and they found out she was a low risk BRCA carrier, but not actually having or BRCA mutation status, and she had a bilateral mastectomy, or she had both of her breasts removed, as saving the world and this and that, and it led to an unnecessary amount of screening and unnecessary essentially mastectomies in very young women just because they saw the celebrity environment and stuff, and it caused a big problem. And it's very difficult to have that conversation with the patient saying, look, your risk of, even if you do the hereditary model, is very low. Removing healthy breast tissue at this point has not been shown to reduce mortality rates. To say that person's really nervous, I just want them out. And so again, that's where 23andMe actually stopped testing for all this stuff. If you take it now, because they cause so much controversy, because the more you test for, is it going to lead to unnecessary stuff? And are people going to demand it? And then is insurance going to approve all this stuff? And then what are the harms of the complications of potential intervention? So genetics sounds great, but really, is it the Holy Grail? So the Holy Grail, I worked on this as a fellow, believe it or not, because my personal belief was the Holy Grail of cancer prevention is if I take a blood sample from you and you say, I'm feeling great, and I detect a cancer cell in your bloodstream in advance and say, aha, you have a cancer cell floating around coming from this source. And here's our risk of this becoming a dying from this kind of cancer, and here's the intervention that would save your life. The problem is cancer is way too complex. I don't think we're anywhere close in my lifetime of having that happen. And the reason for that is cancers go dormant, they don't shed DNA, and so they are much more complicated than just being able to pick up the magic blood test, because a lot of blood tests sound great, but they don't have a lot of action in trying to say, does this help detect a cancer or not? Okay. All right. Next slide. I'm just going to leave it at this. This is a brief overview of briefly Summit Health Cancer Institute, and you can see, kind of what we do. We have all the different support stuff. We have 3 offices in Medina, part-time, and then we have one at Barberton. I'm based at Akron. And then if you go to the next slide, we have a brand new Stowe Kent Medical Center office we just opened. So I do want to give a shout out to that, because this is a beautiful facility. We just are opening that up. So I hope I never see any of you guys as on a professional basis, okay, for what I do for a living. But I just want to give you an idea of here where we are. So, and then next slide. This is just showing you our infusion center where we give all of our therapies. Chemotherapy is just one, but we do immunotherapy, targeted therapy, all kinds of different stuff now. Port maintenance, all kinds of stuff. And then next slide. And that's pretty much it. And this is our main Cooper Cancer Center downtown. So hopefully that did not confuse you guys too much. So any questions?
No, I'm just bringing the mic down.
Come on. Who's got a good question?
Well, I confuse everybody. They're like, yeah, I need to take a nap after that. But hopefully you guys got some idea of where things were going. So.
Could you go back to that pie chart that you did just a few moments ago and explain that one again? I didn't quite understand some of the slices there. Just probably like about four slides ago. That's it.
Yeah. So all this is saying is this is an example. This is called the MyRisk thing. This is a company that basically brought up the idea is, hey, if I sequence out your DNA and I try to say to myself, hey, can I pick up a certain cancer mutation that we know causes cancer early? And that's what they're saying is here that, so like, for example, let me just give you for lung, up to 17%, even though they don't have a lung cancer, could be found to have some of these mutations. And then they're saying that 6.1%, this is just, they're saying the general population risk versus the actual unique risk of each individual person. So what they're basically saying is that, it's individualized, and they're trying to say that testing could pick up things, but what does that really mean in general about actionable, basically doing something about it? And so that's where the controversy is with these testing is, I call it very expensive paper when a lot of patients come in, because we don't know what to do with the information. You get all this fancy, beautiful molecular analysis, 20-page analysis of stuff. Doesn't mean we have a treatment for it. So again, the company loves it because they get tons of money off the fact they're screening all these people, quote unquote. But at the same time, what are you going to do with the information? I think that's key, is that doing all this very specialized testing it has to be fruitful in creating an outcome that you can use that information to both benefit the patient, but also more importantly, help to guide, either a treatment option or closer screening or something of that nature. And that's where we call them variants of undetermined significance, or VUSs. We don't know what to do with a lot of this stuff. So they're there, but the question is, what does it do? We just don't know. So like for breast, if 87% you see some mutation, but what is that? Your hereditary risk, we only know about 12% of them actually have any of the actionable information that we can do something about. I don't know, so does that help? Okay.
Question. I grew up with parents that smoked in the car at the dinner table. And then I had a wife that smoked all her life. I've never touched a cigarette. What kind of risk do I have?
So as of right now, I'm going to give you two hats here. The standard of care is for secondhand smoking exposure. We don't necessarily do any screening. So it's only if you're a primary smoker with a 20-year pack history over the age of 50. That being said, you know, again, so if you were to come to the office, I couldn't get a low dose CAT scan approved for screening purposes. It's just the reality of life. That being said, I do think in the future, it is going to change to, you know, include this, but I don't know when that's going to be. And it also can be variable because you have to, you know, take into a lot of factors of how long were they exposed to smoking, how much, what we call the dose exposure risk. We just don't know a lot of that yet. And so it is little, I think it's probably coming, but if you were to go standard of care right now, there is no low dose CT protocol for secondhand smoking exposure.
Well, it made it to 84, so.
There you go.
Done. Hold your breath.
So going back to this genetic testing, the VA has a program called Million Veterans Program. I think it's a slippery slope.
Mhm.
How much of these numbers are driven by insurance companies that doesn't want to cover anything anyway?
I don't know. I don't work for one, so I can't really say that. Let me just leave it at this, is that insurance companies will not approve things unless it's quote unquote the standard of care. So right now that testing, my genetic risk testing, all this stuff is not the standard. So again, they will not approve it. It's hard for me to say that without saying that whether I agree with it or not. It's just as of right now, unless like there's a lot of things out there when they're testing for circulating tumor cell DNA, they're doing all these fancy things, but it's never been shown to change things right now on a population basis to say, hey, look, this is the standard of care recommendation to include in something called the NCCN guidelines or something of that nature. So all this testing is great and everything, but most insurance companies and stuff will not approve that, and it'll be out-of-pocket costs for most patients.
So who brought up this at 75, you're disposable?
I didn't. Again, but the reality is, the U.S. government has a, a very, robust team, the Health and Human Services industry, where they do kind of look at these things in totality. Again, in their standpoint, almost 90% of healthcare costs are in a certain point of life. And so they say to themselves, is doing more after a certain point in life beneficial or harmful? I think, again, making a clear cutoff is very difficult for me to support because I think each person's different. I think if somebody comes in and they're 75 or 76, they're wheelchair dependent and on 3 liters of oxygen, for a fact they couldn't even tolerate a surgery. They couldn't even go through some of those treatments. Then yes, is screening for that really going to make a difference because the outcome is very different. Then you have somebody who is probably healthier than I am physically. I don't know how you can compare the two. And we're living longer and longer now. And I just think that it has to be individualized based on that approach. And right now it's overview population based.
The other thing I did not see in your stats was the breast cancer that amongst men, as rare as it is, it's becoming more familiar.
Yeah, I didn't include that simply because I didn't want to confuse everybody because it is roughly about 2 to 5% of breast cancers are male breast cancers. But we do not have screening recommendations for male breast cancers. So it's not like we get routine mammograms for males as of right now. So it's unless they feel a mass, then you get a mammogram and other things, or you have a certain family history or other things. But, we don't tell men to do routine breast exams on themselves and stuff. It is incredibly rare, but it is included. Yes, they can happen and all the other stuff, but from a prevention screening recommendation right now, males in general, it is not advised to undergo a mammogram at a certain age.
And I'm gonna say ask another question. I know of 3 young women who are in their 30s that are dying from breast cancer. That is becoming more familiar too, and I don't see any standards changing
Correct.
to try to check them because their breast tissue is more fibrous at such a younger age
Yes,
that is just getting overlooked or missed.
you're absolutely correct. And again, 40 is when you start the screening, right? So going back to like the colonoscopy idea too, younger patients, I had someone the other day, she's 27 with non-hereditary metastatic breast cancer. You know, at the same time, you know, what is the cutoff age? I just don't really know that yet. I really don't. In my opinion, a mammogram is extremely expensive. I think if you pick things up earlier, the better. But at the same time, that's the current guidelines. But I agree. I'm seeing much more younger folks with certain cancers and much more advanced because they didn't have any screening protocol that's approved for them.
Yeah, I started out at 19. I had breast cancer at 19.
Mhm.
And then I ended up with cancer 4 more times.
So you're a prime example. So, I mean, again, what is this arbitrary number cutoff of age? It really is, this is why it's a little controversial in the sense that it's partly out of my control right now, but I do think it's going to be changing, evolving quickly because the younger folks are really the ones with the longest lifespan. Go ahead. And I do think that as time goes on, picking up cancers earlier is going to be the new role, and that is including age. So
I think one of the things we need to, in the medical field, we need to quit using that arbitrarily age thing and deal with people on a one-on-one basis.
could not agree more. And it is very challenging because I have to deal with it on a daily basis on what I get approved for even treatment. You'd be amazed. And again, I can say all this stuff and everything else, but at the end of the day, they go by a standard of care. So it really depends on a lot of different factors, but I do think the future is going to have to be personalized one-on-one basis. I think just to compound everybody the same is really, really an arbitrary way of looking at things, but I'm biased for what I do every day, of course.
Thank you for your time.
Thank you very much, Dr. Pleat. We're going to ask you to stay up here for just a second. We try to make a little money at each meeting with a 50-50 raffle. If you'd please pull a ticket. Big payout today is all of $9. And our number in stand up. Thank you. Very good. Thank you, Dr. Pleat. That was excellent. Total payout today would be $123. So congratulations, Barbara. Let's see. There is a black marble in here. I see it down at the bottom. Oh, now I'm going to bring it around. Let's see. Have at it. And what did she draw? Not one. Thank you very much. Barbara, you're $9. Thank you very much. Appreciate that. Okay. One last thing before we leave. Today is the birth date of the late, great Jackie Robinson, number 42. So let's keep that in mind. Think about baseball's coming soon and have a great day. Bye-bye.